a recording of this. It should be available tomorrow at some point in time, and we'll send out a link to the recording. So here we go. Just a couple of things. Everybody, please keep your computer on mute if you're doing, or your phone's on mute. It'll allow less static and less noise on the system. And if you have a question, please use the chat function, and we'll be looking at the chats as we go through the presentation and answer any questions. Hopefully we'll save most of the questions to the end. So here we go. So once again, I'm Bob DeCidio and Dan Taub, both here tonight. And just as a disclaimer, the information that we're presenting tonight is as accurate as possible. We are certainly not experts in this subject, and we're certainly not experts in Zoom. So please allow us to have a couple little moments if we need to correct things. The situation surrounding the coronavirus pandemic continues to develop rapidly. So it's possible that some of the information that we're presenting tonight may be changed in the minutes that follow. So that's the start disclaimer. Managing COVID-19 for the dental community, safety is our #1 priority. The safety to you, your family, your patients, and others. And what we have to get across to everyone is that the PPE is of utmost importance. We must manage and conserve PPE in order to basically get through the next couple of months. So I'm going to turn this over to Dan Taub, and he's going to talk about the epidemiology.
So just note the date of this presentation is April 2nd, 2020. Information is rapidly evolving, as we speak, even as we put this presentation together over the last 24 hours. To date, the United States currently has the highest number of COVID-19 cases. And as Bob said, please use the chat room for questions and comments. So we have a pretty robust department here. We have 4 outpatient offices. We also cover the VA hospital in Wilmington, Delaware. We have 11 faculty, 20 residents. We have a full ancillary staff, front desk, dental assistants, et cetera, that we've all been trying to keep on the payroll and to sort of rotate in and out through the clinic to avoid exposure. We've certainly decreased our volume significantly. Just for a note, last year, this department across all sites had over 23,000 outpatient visits. And we've, tried to maintain and transition people throughout the hospital, throughout the testing sites to keep some of our employees employed, quite frankly, throughout this pandemic. So this is not new information. People have heard about this COVID-19 now for weeks. It is a group of related viruses known to cause, diseases in mammals and birds. The problem is when this virus jumps from, these mammals and birds to humans, and that's what we're facing right now. There's no specific vaccine or antivirals to date that could combat this. The COVID-19 outbreak, some of the things that we know about the symptoms, and we'll review that in a little bit, is a fever, dry cough, fatigue, dyspnea, or anosmia. Anosmia may be an early sign. The incubation period, as we know it today, is between 5 and 7 days, but it does range from 2 to 14 days. So, a couple of myths, and I think that we're all guilty initially of potentially saying this is, it's just a bad cold, it's just a bad flu. I mean, just think back about, 6-7 weeks ago, we started hearing about the severity of this disease. It was clear there was probably a number of us on the call that just thought it was, maybe just a bad virus. The fact is, the severity of this thing now that we know it, it is clear that it ranges from, absolutely asymptomatic to having severe issues with ARDS, acute respiratory distress syndrome, and then, ventilatory requirements or respirators. It only kills old people, but we clearly know that this is not true at all. Unfortunately, there's been some deaths in young children recently in New York. It's very different from the regular, flu. The reality of it is that most healthcare practitioners, maybe 99.9% of providers are vaccinated against this flu. This is a novel virus, so none of us have immunity to this. We're all susceptible to this. It won't affect me. Well, it certainly, I think, has affected all of us. It's disrupted us in our family lives, our social lives, certainly our work environment. Social distancing. We've had closures to schools. We've had closures to basic restaurants and places that we visit on a daily basis. Certainly social gatherings. So all these myths are no longer our myths. They're our reality that we're living in today. So a little background. SARS, or severe acute respiratory syndrome. This was back in 2002 to 4, and the MERS, or the Middle East Respiratory Syndrome. These had both pretty high mortality rates. I think that in looking over some of this, this was probably what helped contain these viruses was the high mortality rates. We managed to not have any fatalities once these viruses were seen in the United States, as compared to the COVID-19, which, for better or for worse, has a low, mortality rate, to date, 4.5%. The problem is that, as we spoke about before, the symptoms are drag out for a few days, and we could infect one another without even knowing that we're symptomatic. So this is just from an article in the New York Times a few weeks ago. It just charts the estimated mortality of the new coronavirus as it relates to other diseases that we've all seen across the world. The mortality between 1 and 3, and the average number of people that it infects is between 2 and 4 persons. So let's just talk a little bit about the timeline of progression. In December 31st is when the World Health Organization was alerted to several cases in Wuhan, China. And then the novel virus strain was identified January 7th. And January 21st, the first case was found in Washington from a patient that had just traveled to Wuhan. And then it's just been exploding since then. And then, in March, the World Health Organization declared it as a national pandemic. And here we are today. So for those of you who are not from Philadelphia or the Pennsylvania area, just to focus a little bit on what we're dealing with here in Pennsylvania. On March 3rd, the governor, Tom Wolf, reported the first COVID cases in Delaware County. The NBA season was suspended on the same day. On the 13th, the Pennsylvania schools, were closed for 10 days. And then moving along the timeline, Governor Wolf announced a statewide shutdown and non-life-sustaining business going into effect on 3/23. And then on 3/23, actually, a statewide shutdown began, and school closure was extended until April 6th. So just looking at some of the cases in the area here, Pennsylvania, we have over 5,805 cases as of 12 noon today, and 74 deaths. And you can see the breakdown based on the various counties here. We are aware of the significant outbreak in South Jersey as well currently at this time. So this shows sort of a curve, a log curve graph here. So if you look at Montgomery County and Buck, some of the counties that hit early, they're sort of plateauing a little bit and leveling off, whereas in Philadelphia here, as of March 23rd, we're still in this really high, steep curve. So for those local, we thought it would be relevant to list some of the testing sites. I can leave this slide up if people want to take a little snapshot of it. But as Bob said, this presentation will be available through a link or on YouTube, hopefully by tomorrow. So the COVID-19 test that we have now is the PCR testing. We know that this test is actually very specific, but it does have a low sensitivity. So a positive test truly is positive. However, a negative test is not necessarily negative. There's some work, and there's some about the ELISA and the antibody testing, which would be obviously great information to know whether you have immunity or not and can return to work, and colleagues all around the world are working on that. So worldwide cases right now are depicted on the screen, and then cases along with deaths in the bottom here. So when I added this slide, actually, this morning, you can see the time in the bottom left corner there. The total number of deaths were 48,320, and there was 952,000 plus confirmed cases. I just checked it about 10 minutes before this call, and there's over 1 million confirmed cases and over 52,000 deaths in just from between 740 and where we are right now. So this is from the Hopkins website, which is pretty informative, and to look at this graph from my perspective is truly just amazing that this is going on right now. But we've been following this closely, externally and internally. So just a little bit of a breakdown of the cases by country. By far, the U.S. now has surpassed any other country around the world. Fortunately, we don't have as many deaths as some of the other countries have at this point. And then if we look sort of state by state, we see this total number of deaths and what's going on in New York right now. I'm sure everybody's seen the news is pretty scary and terrible. Just another diagram showing the number of cases in the area. So this is, sort of what we're dealing with right now. The U.S. is still on this steep curve, where some of the other countries that you've heard about in the news, South Korea, China, and so forth, have started to flatten out a little bit. We're still on the steep part of this curve here. So the red is the United States, and it's continuing to kind of increase by the hours. So let's just talk a little bit about the social distancing. By no means is this meant to be any sort of politics here. This is just something we felt worthy of discussing. That this was a article. Actually, one of the population health analysts at Jefferson is quoted in this article, and he's tried to emphasize that the importance of social distancing and why we should all take this seriously from what we've learned from what went on in Wuhan. So basically, the best way I think to sort of look at this is that if you look at Italy, Italy had trouble because they sort of overflowed their healthcare system. There was a huge spike. They had to decide who was able to get a ventilator in Italy. They just maxed their healthcare capacity out. So the goal is to sort of spread this out. And whether you're a believer in the philosophy of we're just going to get this disease, and it's just going to happen to us, we tend to disagree with that philosophy, because whether you're going to get it or not, the goal is to just not stress the health system. Basically, you just don't want to decrease all the resources you have within your institution. And if we look at it from a reverse standpoint, let's just say in a population like New York, let's say social concentration, the amount of people that are flooded in the subway, in the buildings, on the streets of New York. I mean, this is looking at it in a reverse way, such as, you know, the social density population, the reason why unfortunately New York is struggling right now. So we just want to, you know, slow the transmission of this disease and keep the curve blunt, so we can all get through this, and hopefully be better off on the other side. The soccer game, which actually I didn't know until we started to do a little bit of research, is being called Game Zero. This was and for those soccer buffs, if I misquote things, I'm sorry, but this is a game between Atlanta and Valencia in Bergamo, and it's been traced back to become one of the epicenters. Basically, this was a biologic bomb. They're saying, you know, the Bergamo, which has a city of 120,000 people, there was 40,000 people that went to this game in buses and drones to root their team on. It was a huge thing. Basically, essentially 1/3 of that city's population were on these buses, and then there was another 2,500 from the neighboring city of Valencia. So please, you know, practice some of these recommendations. Just to show a little bit of the math behind this, and I think some of the symbols of some of the major corporates on the left side of the screen have done some marketing, you know, for this as well. If one person infects somebody, you know, 5 days later, and 2.5 people ultimately become infected, then at 30 days there'll be 460 people infected. If we have 50% less exposure at 5 days, then 1.5 people become infected, and at the 30-day mark there'll be 15 people infected. And then if we go to extremes and then hopefully get 75% less exposures, at 30 days we can have 2.5 people infected. So before I turn this over to Dr. Decidu, we're just going to check the chat room and question line a second. So Dr. Ornstein had asked earlier today if we can look into sort of the N95 mask and sterilization, and whether this ozone technology works. And I just have to report that we are not doing that at Jefferson yet. It is being actually tested whether the N95 mask can be sterilized and reused. Except for right now, the infectious disease department is not recommending that. Now, things might change at Jefferson. What we've been doing here with our emergency patients is they are obviously coming in and we're checking for temperatures, and they're masked and gloved. And then we've been using the N95 masks with an additional mask on top of it. And then we've been using PAPRs for protection for emergencies. So if there's any more comments on that, I'd be happy to make them either on or offline. I'm going to hand over the presentation to Dr. Decidu. Thank you.
So again, if anybody has any questions, please use the chat line and we will answer them as we go through. So what does this all mean to us as dentists in the community? We're all going to get through this. We're all going to survive. We just have another month or so of some rough times ahead of us, according to all the statistics. From what's being said here at the Jefferson Health is that we're probably going to peak in the Philadelphia area sometime next week. And then once we peak, we'll stay at that level for about 4 to 6 weeks, and then we'll start to see a downturn after that. So it's going to be a rough month ahead of us, but we all just need to keep with our social distancing and keep our head straight, exercise if you can, stay mindful, do some meditation, whatever you need to do to clear your mind, and break away from the news every once in a while. That's the most important thing. So how is it going to impact us? So what we all know that our heads are basically, our faces are in line with the patient's mouth. And dentists, dental hygienists, and any of our anybody in our dental community is at one of the highest risks. Also, ears, nose, and throat doctors are pretty high risk as well for disease transmission. So anytime that we're using a dental handpiece, a cavitron, or anything that of those types of instruments, we create aerosols, and those aerosols can take these microorganisms and spread them around the room and to us. So we have to be really, really careful. And we're going to talk about PPE in a little bit. One of the things that you should look out for when you're seeing your patients as we come through the next couple of months is that one of the early signs of people, the mild cases, are inability to smell and inability to taste food. So in about 30% of the cases, anopsia is a major symptom, and that was seen in South Korea. So back in March 16th, the ADA recommended that dentists postpone elective procedures for the next 3 weeks. And as you know, this is now extended to April 30th at least. They want us to be there for our patients for emergencies and to alleviate emergencies that would go to the hospital. Of course, this was all interrupted last week when the Department of Health in Pennsylvania came out with a statement saying that everybody needs to have a negative pressure room in order to do treatment, which was a little bit on the ridiculous side because not many of us had a negative pressure room to do dentistry. So it basically closed down all of dentistry in the state of Pennsylvania. That has been overturned, and now we are able to do dentistry for our emergent and urgent patients with the proper PPE. Patients with acute respiratory illness should be identified at check-in and placed in a single room with the door closed. We should adhere to respiratory hygiene. Cough etiquette, infection control measures should be used. We should offer a disposable mask to persons who are coughing and provide tissues. Ill persons should wear a surgical mask when outside the patient room. Hand hygiene, washing after possible contact with respiratory secretions and contaminated objects and materials is essential. And there should be routine cleaning and disinfection. That was all back in March 16th. So just yesterday, the American Dental Association came out with two areas. One is they talked about how to keep dentists at the lowest risk of transmission. And this was a statement that came out from the ADA. They said, for the lowest risk of transmission, you and your staff should have N95 masks fitted to your face. So basically N95s come with two sizes. They come in a regular size and they come in a small size. So there's actually a fit test that you should do. And I believe something came out actually late this afternoon or early evening from the American Dental Association on how to get fit tested. Most people will take a regular size N95. So you should have an N95 to protect yourself. Or you should have a full face shield and basic clinical PPE. And then you should use approved disinfecting procedures after each procedure. Moderate risk of transmitting the disease from your patient to you or from you to your patient would be just using a full face shield, basic PPE, and disinfecting the room, but no N95. So of course, if you want the lowest risk of disease transmission, you'll have an N95 mask. So there was also yesterday a publication, the interim guidance for minimizing risk of COVID-19 transmission. And if you didn't get this email, you'll have this link tomorrow, or you can take a picture of it now. And this goes step by step of what to do before treatment, during treatment, and after care. And it's a pretty detailed, like a 4 or 5 page guidance on what to do in all these scenarios, how to get the room ready, how to get the patient ready, what to do while the patient's in the chair, and how to clean the room afterwards. So I recommend looking at this document. The American Association of Oral and Maxillofacial Surgery guidelines, they recommend continuing following the CDC guidelines and restrict hospital elective surgeries in order to free the hospital beds. What we're trying to do here at Jefferson is keep our patients out of the hospital, our emergency patients. We don't want them to go to the emergency room. We want to treat as many patients as we can in the office setting. The AMIS also has requested to screen patients, ask them about upper respiratory infections, flu-like symptoms in the past 14 days, and any recent travel. If any of these things are yes, upper respiratory infections, flu-like symptoms, or travel in the last 14 days, and they have a fever over 99.1, then of course we're going to delay the surgery for at least 14 days if possible. The AO CMF, International Task Force, basically says the same thing. Surgical procedures involving the nasal oral mucosa regions are at the highest risk. Asymptomatic patients may be infected with COVID-19, so we need to treat all patients as if they had COVID-19. That's basically the theory here at Jefferson. When we're treating any patient, we're treating them as if they have COVID-19. Because what Dan was talking about with the specificity and the sensitivity of the test is, even though the test comes back negative, we're not really sure if that's a true negative or if that's a false negative. That goes back to your days of statistics. Appropriate PPE should be worn during surgical procedures, and again, N95 full face shields or PAPRs are very important. Intraoral operative procedures, please limit the generation of aerosol viruses. The state of Pennsylvania, back in March 19, the Secretary of Health, Dr. Rachel Levine, signed an executive order which prohibited elective medical and surgical procedures during the duration of the COVID-19 emergency. And then this is what eventually led to the closing of dental practices for about a week. So this is how we do it here at Jefferson. So if we have a patient that calls for an appointment or has an emergency or needs to come in, we pre-screen the patient with a phone interview. So our receptionist will take the call. They will then set up a telehealth visit with the patient. The telehealth visit will be run either by a resident or a faculty member. And we determine through that telehealth visit if it's a true emergency or an urgent situation. Of course, if they're bleeding, they have severe facial swelling and abscess trauma, and they need to come in. If it's something that can be held off with antibiotics and pain medications, we do go that route. If the patient has COVID-19 symptoms, such as fever, cough, shortness of breath, myalgia, and a toothache or swelling or something like that, we would like to get them tested first if possible. But of course, like I said before, we're treating all patients as if they are COVID-19 positive. So the governor's proclamation of disaster emergency occurred this week. The following procedures must be implemented at sites for emergency dental care for any patients with known or for patients under investigation for COVID-19. If an urgent or emergent care is required, you must provide the patient with a face mask upon entry to the office and guide the patient to the procedure room, as we said before. The patient is asked to wash their hands with soap and water for at least 20 seconds. And what we're doing here at Jefferson is we're using antimicrobial mouth rinse. We use chlorhexidine, and they rinse with chlorhexidine for at least 30 to 60 seconds prior to examining the patient. We are actually limiting the amount of people in the room, just as the governor suggested. We're keeping 2 people in the room. Actually, we're not allowing our lower level residents to even be involved in patient care because we just want people that are experienced who want to go into the room, get what needs to be done, and then move out. Our personnel are using N95 masks, which is required. And it's also, you need to learn how to use a PAPR. We're using PAPRs here, and it's a little bit difficult, but we learn with the PAPRs, you have to get into the PAPR and out of the PAPR in a very specific manner. And as I said before, we minimize the number of dental health care personnel in the room at any one time. For aerosol generating procedures, we use a high volume evacuator and a rubber dam when possible. Place a clean face mask over the patient's mouth and nose and ask them to wash their hands per the CDC guidelines before exiting the procedure room. As we said before, they're going to use alcohol-based, they're going to wash their hands for 20 seconds or use alcohol-based hand rub. So this is just a little diagram just showing an infected patient over on the left-hand side, and their droplets when they're coughing. They're going to pass that on to susceptible individuals. If that person was in the dental chair and we're using high-speed drill, and they are infected, then those droplets will get spread to the dental professionals and back to the patients. So that's why we have to be really careful here. So regarding PPE, many things encompass the PPE. The N95 mask is our most important thing right now for dentists that are going to be doing procedures. So if you don't have N95 masks, I would suggest trying to get some. We are using our N95 masks for about a week, and then we are saving them. And as Dan said, there is a plan to try to re-sterilize the N95 masks, but nothing has been decided yet according to the CDC guidelines. So we're putting glasses on, face shield, N95 mask, head cover, gowns, and gloves, basically for all procedures. This is just a little bit about our inpatient guidelines that we don't really need to go over for this particular, in this particular scenario. But once again, we treat all patients as if they're COVID positive. And once again, this is our policy for oral and maxillofacial surgery, universal screening and prioritization process. And all patients are considered COVID positive. So I wanted to switch gears just a little bit and talk about telemedicine. So telemedicine has been around for a long time in oral and maxillofacial surgery from 2016. This was like one of the first articles. We here at Jefferson have been using telemedicine for a couple of years since our CEO, Steve Klasko, came on board about 4 or 5 years ago. We were typically using it for post-op visits. Now we're using it for consultations and screening patients, as I said before. But it's been a great tool, and the rules with telehealth have relaxed quite a bit since COVID-19. And I'll just go over a couple of things here. This is Judd Hollander is our COVID-19 guru. He implemented the process here at Jefferson, and it's not something that makes a lot of money, but it actually helps streamline your patient flow. So a little bit about COVID-19 updates to telehealth coding. So you used to only be able to do telehealth in the same state where the patient was located. So if I'm in Pennsylvania and the patient's in Pennsylvania, then I can do the telehealth visit. If the patient was in New Jersey and I'm in Pennsylvania and I don't have a New Jersey license, then I couldn't bill for that telehealth visit. All those things are relaxed now. So you can go state to state and you can do telehealth visits from state to state, any geographic location. The other thing is co-pays can be waived if needed, so the patient doesn't need to pay a copay. And there's different platforms for telehealth. We use telehealth through our Epic, our electronic medical record, but you can do FaceTime. There's another one called Doxy.me that you can use for telemedicine calls. And this is just the originating site where the patient is located. The distant site have to be HIPAA compliant. There's synchronous and there's asynchronous billing with regard to telehealth. And then this is a little about the coding, and I'll give you all this when you have the presentation. You can see the coding. With regard to dental visits, the most important one is I'll switch to it over here. This is nude patient. These are just all coding. So if you're billing by level, you can almost get up to an L3 level in your coding. It's pretty hard to do a full physical exam while you're doing telemedicine. The teledentistry codes, there's the D9995 teledentistry, that's synchronous, real-time encounter reported in addition to other procedures, diagnostic delivered to the patient on the same date of service. And then there's D9996, which is teledentistry asynchronous. So these are the two D codes that you can use for teledentistry. Now, remember, these codes aren't going to reimburse a lot. They may only reimburse $10, $15, but at least it's some finances coming back into the practice, and it keeps you in touch with your patients. So if they do call for an emergency, you can do this teledentistry visit and then decide whether they need to come into the office or not. So just as an ending here, we're all in this together. We wish everybody luck in this new adventure that we're on, and hopefully we'll be through this within the next month and a half. And I'm going to open it up now to any questions that anybody has. We can look at the chat if anybody put any questions in there, or you can actually come off of mute and then ask the questions yourself. So any questions from anybody? I think we have 4 on the chat line. So I have Dr. Abbott asked, I have installed a negative pressure room in my office. How much protection am I really getting? So as far as the negative pressure, I think that I'm not an expert here at all. You are getting some protection, but that doesn't mean that you need to not wear your regular PPE. Even with negative pressure, you're still required to wear an N95 mask and to have all the other PPE. It's only what negative pressure basically is going to do is going to take the virus out of the room and send it into another area through a HEPA filtration system.
So below that is an article actually that we posted for you, Allison, to take a look at. That's a good reference for you in regards to negative pressure.
And then there's another question. I am not getting any N95 mask anywhere, only on eBay, and I don't know if we can trust them. I have emergency patients, not sure how else can I see them. So as I talked a little bit before about the different levels of disease transmission, so if you want to have the lowest risk of disease transmission, then N95 mask is the way to go. If you want a moderate disease transmission, then a face shield and a regular surgical mask will give you moderate disease, will give you moderate protection. The thought process that I've heard through infectious disease is that regular surgical masks to combat against COVID-19 in a non-aerosolizing situation is sufficient. But if you have an aerosolizing situation, then you definitely need to have the N95 mask. And Dr. Ornstein, will you remain as an info resource into future weeks? Absolutely. We can do this again in another week or two if people would like. Just email us and we'll be happy to do this again. And Dr. Manlowski, can general dentists order N95 for emergencies? Where is the best place to order them? I think, Michael, I think I just saw something from the ADA that lit this afternoon or late or early this evening that mentioned about obtaining N95 masks. I'll send everybody out that link in case you didn't have it. Are there any other questions from anybody?
Thank you for your time, guys, and your help.
Pleasure.
Thank you. Thanks for listening, everybody. So if there's no other questions, then I think we will we'll call the meeting over, and we'll have this recording sent out to everybody by tomorrow.
And we just wanted everybody to know that that number, that will be inside. We are open for helping the community out and helping our friends, family, colleagues, during this hard time. So feel free to use us as a resource if you desire.
We have a couple more questions here, just real quick. So Dr. Ling wrote, how are you handling the N95 masks that you are wearing for a week since you can't re-sterilize? So right now at Jefferson, we're just asked to put them in a bin after we wear them for a week. And then if there is a sterilization system, then we will give them back to the central people here at Jefferson. They would sterilize them and then hand them out again. But there's no plan for re-sterilization right now. I think we're waiting for some CDC guidance on that. And then there's another question from Dr. Woljan. Should I consider wiping a tooth with sodium hypochlorite before making an endo access once the rubber band is in place? I would say, Josh, I have no idea because I'm not an endodontist, but if it helps sterilize the area, I would say absolutely. All right, well, thank you all. Thanks for joining us tonight, and we will send everything out tomorrow. Take care. Good night.